Welcome back to this edition of Your Health, Your Wealth, the show where I try to explore the intersection between medicine, wellness, and the human side of healthcare. I'm your host, Dr. Patton, and excited to be here with you today. I want to talk about today a topic that in the healthcare field is getting a lot of attention, and we're talking a lot about the impact, and that is physician burnout. I've often said that medicine is a calling. It's not like most other professions because it's your job to take care of other people, and with taking care of other people, you have to take care of yourself as well. And today we're going to be talking about physician burnout, and the key thing is that physician burnout is not just a bunch of physicians complaining about how hard things are. This is a serious issue that affects patient care and can lead to things like physician shortage when it comes to healthcare. So physicians constantly battle between exhaustion, emotional fatigue, moral distress. So today we'll talk about burnout, why it's on the rise, and what it costs the profession, and most importantly, what can we do to change it, and how it affects patients and how we practice medicine. So let's start with the numbers, as I often like to do, and start with the general explanation. So, according to a recent Medscape paper, nearly 50% of physicians, so that's 1 in every 2 physicians, say that they either feel burnt out or are experiencing some signs of burnout. And it's important to understand that this is a spectrum. There are different aspects of burnout, and so different physicians are on different parts of that spectrum. But in general, about 50%, 1 in 2 physicians, and this is up from around 42% just before the pandemic. And we see some of these higher rates of burnout in professions like emergency medicine, primary care, neurology, and OBGYN. And when you look behind the statistics, when you look at the actual story of what these clinicians and physicians are going through, a lot of it has to do with the administrative burden of what we have to do. There's so much that we have to do outside of just direct patient care that it can lead to exhaustion and feelings that your time is not worth it. And so overall in medicine, this is something that we're constantly working on, particularly as we go into consolidation where more and more physicians are working in these larger groups. It's important for administrators to get a hold of this situation to decrease turnover and different things like that. So when we look at burnout overall and what is it exactly, it is a work-related syndrome. So this isn't like just someone having a bad day or depression or other things like that. This is work-related. It involves emotional exhaustion. There's depersonalization. And there's a sense of reduced personal accomplishment. And by that, it means that you kind of feel like what you're doing, is it really worth it? Am I really getting the support that I need to keep doing what I'm doing? It is a public health crisis because of its impact on not just individual physicians, but on the overall healthcare workforce as well. Some things I frequently hear from doctors, they say they feel used up at the end of the day. And what you'll see is it actually affects how physicians practice and can lead to things like medical errors and so forth. I have had colleagues who have left clinical practice to do things like work for pharmaceutical companies, photography or arts or just different things like that. Not because they didn't love taking care of people or didn't feel that it was important to take care of people, but just because there was this overall feeling that they were being treated more like an object rather than a human being or as a physician. So those are the types of things you hear when you're specifically looking at burnout, and in that it's, again, not just fatigue or being depressed, that it is a specific phenomenon that's going on through healthcare, and we're seeing these numbers increase. Physicians, at least most physicians that I know, went into medicine because of a deep purpose. They wanted to take care of people. They wanted to make people better. But unfortunately, when a lot of these administrative burdens start really kicking in, such as electronic health records, there became more paperwork and battle with just sitting there clicking away at a computer, inputting data, and also battles with insurance companies over things like prior authorization. So in all of that, what gets crowded out is the patient-physician relationship and the patient care that's at the foundation of healthcare. So there's just this constant over time, just this erosion, this breaking away of the actual joy that as to why most people went into healthcare. And this isn't a personal thing because, as I mentioned, you see the numbers going up. Almost half of physicians have some signs or symptoms of burnout. So it's not just personal. This is a systemic thing. It's affecting the whole healthcare system to the tune of billions of dollars per year in things like physician turnover, lost productivity, and you're seeing issues with quality of care because of burnout. So when you think about why is this an important thing to talk about and the consequences of burnout on a large scale, we have good, solid evidence that burnout is having a profound impact on the healthcare system. It's associated with negative consequences in patient care, the physician workforce, and healthcare system costs. There's already a shortage of physicians, and when there is physician turnover, meaning that you lose one doctor and you have to bring in another one, it costs a practice or a system a lot of money to do that. And on top of that, particularly if we're seeing these higher rates of burnout in older physicians who typically stay in practice and pass that information along to a younger colleague to keep it going, and that's how the cycle continues. So now physicians are retiring sooner and leaving the workforce. It has implications when it comes to physician safety and actually how, again, these medical errors which can occur when a physician feels burnt out. We've seen increased in physician things like substance abuse, depression and suicide, self-care, and even motor vehicle accidents. Increased motor vehicle accidents have been attributed to burnout. So it goes beyond just physicians being tired or fatigued. This is a systemic issue that has really long-term implications, because if you decrease the workforce of physicians, then guess what? For patients, that means longer wait times. That means shorter visits with your physician because they're trying to see so many patients per day. We want this to be an attractive field, meaning healthcare, where young talented students in college will want to go into medicine. But unfortunately, when you look at these stats and what's going on, we're having issues or some problems with really getting young talented people to go into medicine and fill that workplace shortage or that workforce shortage that we're seeing from more and more physicians retiring. So the first thing that we had to do was, really understand the problem. Why did we see this issue with physician burnout start to really trend up? And over time, and again, there are different points throughout the healthcare evolution with EMR and different things like that. But over time, there started to just be this trend. And so we figured out that we can't fix what we don't understand. So there started to be more of these studies that went into looking at workforce and looking at physicians and trying to figure out what's causing burnout and what's contributing to burnout. And one of the key things that was found was just system overload. There was just too much other than just taking care of patients that was going into medicine. In the past, a physician went in, you talked with the patient, you interviewed them, you examined them, you came out with a treatment plan, and you instituted that plan. Now you have to go in, you have to talk with the patient, and you have to input all that data. You have to make sure that you've met all of the regulatory requirements regarding that patient visit. You got all this information you have to put into the EHR. And one thing that I'll say about the electronic health record is when we went through this whole revolution of EHR revolution, in essence, I think the idea of what we were trying to do with electronic health records, as far as making sure that that healthcare is transparent, making sure that that a record follows a patient, that was good. But for the most part, it became more of an insurance thing. It became an audit tool, not more so like a clinical one. I could reduce my notes so much if there wasn't so much just information that I had to put in the record. And a large part that is because of one of the second big issue, which is this regulatory issue and payer demands, where the insurance companies are really pulling or taking away the physicians from the patients to have to make sure that you document so much stuff to get things approved. It's one thing to say, I figured out what's going on with this patient and this is what I want to do. But then it's a whole nother thing for that to actually get done, because now I have to order it, has to go through the insurance company. They have to approve it. If it's a medication, you have pharmacy benefit managers involved. There's so many different factors that go into this decision. Well, not really the decision, but carrying out that decision and making sure that the orders are filled. So this regulatory thing, the payer demands, it really kind of pulls physicians away from taking care of patients. And part of it is our fault too as clinicians, because we have this expectation of ourselves to try to be perfect. You don't want to make mistakes. A lot of times you have you're dealing with life and death situations. You have a patient's morbidity and mortality at your hands, and now your fingertip. And so that's a lot of pressure that you put on yourself to try to be error-free and try to not make mistakes. And it's hard sometimes to ask for help, but that's really on physicians to really understand that and to make sure that they're doing the best thing for patients. Because ultimately this leads to exhaustion. If you keep going, burning the candle at both sides, there are terms in literature called pajama time, meaning how much time when you leave clinic and go home are you still at your computer, doing work, putting in patient records, reviewing cases. And research has shown that if we can reduce that pajama time and give people back their life when they go home, it helps to balance things out to where you have that life satisfaction. And then when you get up, go in the clinic the next day, you can totally focus on taking care of people. So now that we've examined the problem and we see the impacts that this can have on patient care, and if you're sitting back and you're listening to this podcast and you say, well, that sounds like it's just a physician problem, and how does that impact me as a patient? Well, if you go in to see your physician and they're not fully engaged or being able to really lock in on the visit because they're so worried about either what's going on in the practice or how they're going to pay their staff, it can affect how they are really locked in on you as a patient, and can they really formulate the right diagnosis and treatment plan moving forward. So it absolutely affects everyone in this healthcare system. We're seeing now private practices are consolidating, shutting down, or joining larger systems because they don't want to deal with a lot of this administrative burden and what goes into to this issue regarding burnout. So moving forward, I don't think there's a single cure for this. There's no prescription that we can write for this problem because it's both a personal issue and a systemic issue. But there's some overall things that we need to look at and try to enhance. So from a system level, the key issue is trying to figure out how to reduce clerical burden, how to figure out how to reduce this administrative burden that doctors have to go through so that most of the time a physician can use doing what they're supposed to be doing, which is clinical work, which is taking care of patients. If you're a radiologist, being able to just focus on reading films, or pathology, reading and interpreting pathology. So how do we redesign workflows so that there's less of this interruption and less of this burden that's really tasking physicians every day? And this is done a lot of different ways on a local level, working with your administrators, looking at processes in the office to make things cleaner and smoother, making sure that you have staff that can help you, and training that staff to offset as much of these kind of administrative or mundane tasks that you don't necessarily need to do. It comes through advocacy, meaning advocating with state and national government to reduce some of these regulatory burdens that clinicians have, and that really interfere with the patient-physician relationship. And that's one thing that I've been passionate about throughout my career is advocating for patients and for my profession to make sure that doctors can be doctors, and that we are allowed to have the time and the autonomy to do the things that we need to do. And if we do that, then that can reduce burnout. In my opinion, I think healthcare is going towards more of a team-based approach. And within that team, you may have your medical assistants, physician extenders like physician assistants or nurse practitioners to help. A lot of times, for instance, in my practice, if I have a long new patient wait, so we're trying to cut that down so we can get new patients in as soon as possible. If there are things like follow-up visits where patients want to go over results and so forth, I have a nurse practitioner now that I can say, hey, you're going to come in, you're going to see my nurse practitioner. I'm going to see you as well, but That way we can get more people in. So using a team-based approach can certainly help with healthcare and help reduce burnout as well. One of the things that I'm excited about is technology and how technology is going to help us. For instance, artificial intelligence. I use artificial intelligence scribe. So if you think about what is a scribe, scribing is the process of taking the patient visit and capturing it and then documenting it in a way that fulfills all of these regulatory and administrative challenges and just the things that are needed. And we've gone through several iterations of what makes this better. Way back in the past, when you read medical history, a physician note used to be a paragraph long because that's all that was needed. You just need to know what was the diagnosis. You can summarize your exam, and then, hey, what are we going to do? Now, there are pages and pages of things that you have to have documented in order to bill, in order to go through prior authorization and different things like that. So how do we make that process so that you're not spending more time on the computer? There was a study that was released a couple of years ago that showed that I think it was more than almost 2/3 of a patient visit was used just input data to the EMR as opposed to just 1/3 that was actually talking to the patient. That needs to be reversed. Most of the time needs to be talking with the patient during the visit, not putting information to a computer. You can use live scribes, which are actual people in the room. Different people have their opinion about that, and does that feel intrusive and so forth. I lately have been using an artificial intelligence scribe, which is a pretty cool program. It's on my phone. I set it on the desk, and I can put my computer down and really just have a conversation with the patient, examine them, and then with the touch of a button, the AI system populates that note. It looks at certain ways to document things, and it takes out a lot of the general conversation I may have with patients, and it gives me a note that I then, you still have to have that human element, so I still have to proofread the note, and it has really cut down my documentation time, finishing my notes at the end of clinic as opposed to taking them home and having to finish notes at home. So not just with scribing, but with a number of these administrative tasks that we can create an AI algorithm to help us. I do think that technology and artificial intelligence is going to be a part of this solution to help with burnout. And we even, we have evidence and studies now that are showing that even AI scribing are helping to reduce burnout among physicians. We have to encourage our hospital leadership, our system leadership, to look at measures and really track staff well-being. Depending on your competitive environment, there was this notion that, especially if you're an employed physician, that it's best not to say anything. Just try to suck it up because, you're replaceable. These systems can fire you and just bring someone else in. Well, when you look at the cost of retraining a physician and physician turnover, it makes more sense for hospitals and systems to invest in burnout prevention and paying attention to physicians and seeing what's going on rather than trying to bring in another physician or just saying that this doctor is burnt out. We need to look at the reimbursement system in our country, in our healthcare system. Physician reimbursement has gone down. When you look at, we call it the Medicare flat line, where there's a graph that shows that when you look at the inflation, it's going up. But when you look at physician reimbursement, it's been a flat line. So we have not made those adjustments in physician reimbursement for things like inflation. I mean, it costs more to just keep your lights on in the office. It costs more. Staff is asking for more as far as salaries, equipment. And if the reimbursement system is not increasing, then the only way you can make up for that is through volume. And when you have volume, we're not trying to produce cars here or a widget. We're taking care of patients. So when you have to increase volume, you mean shorter appointment times, and all of these things lead to burnout because you're trying to get more and more patients in. So we need to restructure that and incentivize and pay physicians based on outcomes and their patient-centered approach, as opposed to volume of patients that are coming in. And then on a personal level, there are some things that clinicians can do themselves to help to prevent or mitigate this burnout. One is things like mindfulness meditation, setting boundaries and making sure that you as a physician are aware that I need to take care of myself before I can take care of others. I am very encouraging of peer group discussions on this, open discussions among medical groups, societies like county medical societies, within the Harris County Medical Society, which is the society that I'm a member and part of the leadership team. We're actively looking at this issue and looking at ways that we can get physicians together to talk about these things and to figure out strategies to try to overcome burnout. Sometimes we have to learn how to say no. Say no to some non-essential tasks. Talk with your administration and say, look, I'm not trying to be difficult, but if this isn't adding to the patient-physician relationship, if this is taking away from what I'm trying to do to take care of patients, then this may not be something that we need to implement or something that I can do. And that's important that we're having these real conversations about this issue on a systemic level, because it's not just a personal issue, it's also a systemic issue within these systems. And a lot of administrators, I call it governed by spreadsheets. So they're making these decisions based on an Excel spreadsheet and numbers and data that are coming in, without actually spending time in the clinic and talking to physicians and talking to patients and seeing their workflow and how they get through a day. So those types of things, that communication between administrators and physicians, will really help to break down this issue of burnout. So we can't normalize burnout as just a part of the job of being a physician. There has to be a shift towards more, endurance, empowerment. We want to get more and more medical students to want to go into physician, to go into being a physician. So mitigating this problem and letting them know that this is still it's a great profession. I love what I do. I think it's a noble profession, and it's a calling. It's not just a job, but hopefully through working with systems and advocacy, we can really mitigate this problem. And also, on a personal level, for a physician, we have to find those other things that give you a break, that give you that non-medical mind freedom or break from what you're doing, whether that be working out or meditation or art or photography, just anything that you can do to turn it off sometime. And that's difficult to do. And certainly earlier in my career, I had a hard time turning it off. Like, I didn't know when I came home, I was still thinking about clinic and still thinking about patients, and I'm logging into my electronic health record, checking this, checking that. Like most other things, you do have to turn it off sometime and figure out what are the things that I can incorporate into my life to help to kind of turn this off and reduce the risk of burnout. So physician burnout is a trend that we're seeing in our country. It's something that everyone should be aware of because of its long-term effects on healthcare and patient care. I am excited about the fact that we are doing more studies into this. We're looking into mitigation, things to mitigate this problem, make it better. But it's going to come from a systemic level as well as from a personal level. This is going to involve advocacy and understanding that in order for physicians to be able to give 110% as we do every day towards taking care of others, we have to address this issue of burnout to make sure that we're taking care of ourselves as well. Healing and healers isn't optional. This is essential to our society. So we need to protect our physicians. And the future of healthcare depends not only on innovation, but on well-being for those who are delivering healthcare. So I do think that we'll be able to use innovation and technology to help with this issue. But in the end, we have to keep the conversation going. Physicians have to exercise their voice and speak up and know that you're not alone if you are experiencing any of these signs and symptoms of burnout. And for patients, we should have a higher level of accountability for our health insurance plans and places where we go to see our physicians to say, hey, I want to be taken care of, so let's make sure that we take care of our physicians. And over time, we can reduce those rates from 50% of physicians to hopefully zero and create a system where our talented young people want to go into healthcare and want to practice medicine and want to take care of people and aren't afraid that they're not going to be taken care of themselves. So if you enjoyed this episode, please share it with others and tune in for future editions of Your Health, Your Wealth. I'm your host, Dr. Eddie Patton, and I've enjoyed having this conversation with you about burnout and ways in which that we can fix this problem moving forward. Please subscribe to the show, and I look forward to talking with you on future episodes of Your Health, Your Wealth.